We invited almost every community at that time to go to the American Diabetes Association and European Diabetic Association and to listen to docs like Peter Bennett. So he brought them here to India way back in 1982 when diabetes itself was not known in the country. So that's the origin of the DRC Gold Medal Oration. This year, along with the Professor.M.Viswanathan Gold Medal Oration, we are organizing a session on improving the health of women with diabetes. And I'd like to present a few slides for just 4 minutes on the issue of diabetes among women. Now, when we do studies in medicine or in diabetology and so on, we do not specifically look at problems in women. We take men and women together, then we do statistical analysis and see whether there's a difference between men and women and so on. So most of the studies which are published have looked at men and women together. So what I did in the last few days was I looked at some of our own studies done at the Professor.M.Viswanathan DRC and tried to sort of piece out the information on women. And the next 4 minutes, first slide, I'll show you some of the data which I'm going to present will actually pave the way for doing research in India on women with diabetes. Out of 3 women in India will develop heart disease, heart attacks, compared to 1 out of 9 women who will die of cancer. So he was talking about the very, very, very high prevalence of heart attacks, heart disease. And he also said this morning that women are more likely to die than men from a first heart attack. So when you go with a heart attack to a hospital, he said women usually are brought dead than men. So these are all startling facts, but we don't have much data, unfortunately, in India. So, the next slide, show it here. Okay, here. Okay. So the facts about here. Okay. So there are currently over 199 million women living with diabetes all over the world, and this is projected to increase. But if you take this diagram and you see that, does this mouse work? This one? Yeah. If you see this show me, okay, after the no, I wanted to show the first previous slide, this one. With the mouse. Oh, this way, okay. So if you take cardiovascular disease, so mouse is still not working. Okay. So there are 2 projections, that's right. Can you make this mouse work? No, but it's not working. If you add heart disease, cancer and diabetes, it constitutes about 70% of deaths of women. No, previous slide, mouse if I move, no, the thing is, you're not doing what I tell you to do. The mouse is not working, leave it, it's okay. Forget it. Okay. So if you take this slide, you'll see that heart disease, cancer, which you see in the red color, and diabetes, which you see in the orange color, constitutes about 70% of all deaths of women. This is data from WHO. And diabetes is supposed to be a leading cause of death among women. I think it's a very important fact. Now, this was studied from the ICMR. And why I'm showing that is because this is the only data available in India today on the prevalence of diabetes across India. And you can see that, unfortunately, the mouse is not working. You can see that until the age of about 60, men have more diabetes than women. But if you cross the age of 65, according to the study, women have more diabetes than men. So if you take men and women above the age of 65, according to the study, you can see that women have more diabetes. Now, though men have more diabetes than women, the number of people dying from diabetes is more among women than men. This is data from the United States. You can see that from the age of 35 to 74, you can see that the mortality, the death rates of diabetes is coming down in men, whereas in women it's actually going up. Therefore, below the age of 65, in women than men. But the number of women dying from diabetes is more than in men. That's a very important point. Now, what are the reasons for more diabetes in women? This is a study which we did among the slum population. There's an area called Paramarkoti and Jeevarathan Nagar in Noyapam, Kasimedu. I don't know how many of you have heard of these backward areas in North Madras surrounding our hospital. We found that in this study, the prevalence of obesity, prevalence of overweight was much higher in women than in men. You can see that if you take obesity, overweight, whatever it may be, women, even the poor women in Chennai are more obese than the men, probably due to sedentary lifestyle and whatever. One of my epidemiologists, Dr. Shabana, she looked at the obesity rates in men and women in Chennai city from 1995 up until 2008. And you can see that the square columns are the women. The prevalence of obesity among women in Chennai is actually increasing much more than in men. Therefore, women are gaining more weight, they are more obese than men. The metabolic syndrome, which is high blood pressure, high diabetes, high triglycerides and so on, is actually also more in women than men. So this is probably the reason why women are getting more heart attacks and more serious heart attacks and so on. What about children? So this was a study which we did comparing children who attend the CBSE schools like Padma Sheshadri and Bhavan's Rajaji Vidyashram versus the corporation schools in Chennai. And we found that if you take the higher socioeconomic education schools, you can see that the girls, whether they were girls or children or adolescents, the women. So even at school age, I think the girls are more obese than women, which goes on to the adult age. It's not working. Next slide. Some problem with this. You can see that studies have shown that every single complication on diabetes, like increased proteinuria, high depression, stroke, mortality of the renal replacement therapy, is all higher in women than in men. And as I told you a little earlier, when women get diabetes, their risk of dying from heart disease is much more. And this is not working. So you can show the next slide. Now, this is a study going on in Pakistan and India and 12 diabetic centers, where they have employed a care coordinator to look after patients with diabetes and a control group which takes standard care. And you can see this is called the CAR study, Center for Cardiovascular Metabolic Risk Reduction in South Asia. And the MV Hospital was one of the centers involved in these 12 centers. Next slide. And you can see that if you take the men, they do seem to be doing better than women among the patients who get the intervention. So the response to treatment, the response to intervention seems to be better in men than women. This was a study which we did to find out how many of the people by intense education move from a HbA1c of 10 to 7. And you can see that in men, the number of men who moved from 10 to 7 was more than the number of women who moved from 10 to 7 after 3 months of intensive education. So the response to treatment, the response to intervention also seems to be better in men than women. Kidney failure. Now, after the first year, after the dialysis started, this is data from France. I'll show you the data from India next. You can see that during the first year, second year, third year, fourth year, fifth year, after starting dialysis, more women die than men when they have dialysis and kidney failure. In India, from Bengaluru, we have a study which has shown that the survival rate of women is only 20% during hemodialysis compared to men who live much longer than women. And recently we looked at the angiotensin converting enzyme gene. It's a very important gene on chromosome 11, and there is a particular allele called D allele. And we found that those who have the D allele or the D genotype are supposed to progress faster for their kidney disease. Now we found that more women have the D allele than men. You can see that the odds ratio is much higher, statistically significant. Therefore, the DIL is also more common among women. Therefore, having said that obesity is higher, diabetes response to treatment is better in men than in women. Kidney disease, heart disease is much more in women. So having said all that, I think the health systems must pay adequate attention to the specific needs and priorities of women, and they should be given more access to this essential diabetic medicines and so on. So with this, I think, as I said before, I think this paves the way for future research of women with diabetes, and we need to do a lot of work for that. And that is why we decided to start a specialized women wellness clinic at our hospital in Royapuram. And this specialized clinic for women with diabetes will screen them for silent diseases like thyroid disease, hypertension, heart disease, cancers like breast and cervical cancer, kidney disease and bone-related issues, which will help them to avoid fractures. It will be run by a gynecologist with the entire backing of our team of sonologists, diabetologists, diabetes educators, and dietitians and so on. And we hope to collect very important research data on women with diabetes with respect to various diseases with the help of our scientists at the Professor M.Viswanathan Diabetes Research Center. I thank you for your attention. Thank you very much.
For highlighting the problem of diabetes in women. May we now invite clinic in MV Hospital for Diabetes and Professor
Professor M.Viswanathan Gold Medal Oration 2018 to Dr. V. Shanta, Chairman of the Cancer Institute, MBS in 1949, the DGO in 1952, and MD in Obstetrics and Gynecology in 1950. In the Women and Children's Hospital, Madras, to which she had been selected by the Madras Public Service Commission. Dr. V. Shanta's entire medical life, over 50 years, has been dedicated to the mission of organizing cancer till March 2005 and the convener of the State Advisory Board on Cancer. She was also the chairman of the Indo-US Collaborative Group on Lymphoid Neoplasias, the Indian chapter, and member of many ICMR committees. She's been honored with many various international and national awards, including the International Association of Cancer Registries, the Nasli Gadel Malwa Award from Brussels, the Raman Magsaysay Award for Public Service, the Padma Shri, the Padma Bhushan, and the Padma Vibhushan, and the Avayar Award by the Government of Tamil Nadu in 2013. She has also been awarded with miscellaneous Lifetime Achievement Awards by different organizations and universities for her contribution to the advances in the management and control of cancer. Dr. Shanta has also received honorary doctorates from various universities, including Sri Venkateswara University, the Tamil Nadu Dr. NGR Medical University, the Dr. MPR University of Health Sciences, and Satyabama University. She has participated in a number of scientific international collaborative programs and has more than 95 publications to her credit.
we request Dr. S.N. Resident to hand over the citation to Dr. V. Shanta.
Basically, I would like to say whatever has been said about me belongs to the Cancer Institute. I am only part of the Institute. Nothing has been achieved individually. I am grateful to all the staff of the Institute for giving me this opportunity. Now, a little correction about the Cancer Institute. The Cancer Institute was founded in 1954 as a voluntary charitable institution by the late Dr. Muthulakshmi Reddy, the first woman medical graduate in India, and a pioneer in women's empowerment. I think many of you have not heard about her. I think she was a wonderful person. She lost her sister of an undiagnosed, untreated cancer of the rectum in 1923 when we were under British rule, and there were no facilities for cancer care at that time in India. For the matter of that, even globally, there was very little for cancer care. It was a dream that she should do something for cancer. The dream that was born in 1923 ultimately fructified only in 1954. That was the obstacles that had to be faced by a non-government, voluntary, charitable institution. It started, the ethos of the institute has been treatment without any social or economic divide. And anyway, I think the story of the institute, which is about 64 years now, I have been with the institute. I think it will take another minimum 60 minutes maximum. So I think I won't go into that. We are a purely voluntary organization meant for the underprivileged. Of course, we have to have the paying patients also who support the non-paying patients. Now, having finished that, I think I have to go to the theme of today's lecture, the cancer in women and diabetes. Well, and I don't think you should expect a very erudite lecture. It is going to be purely facts, and majority, all the facts on cancer has emanated from India, from the institute which has contributed a great deal in the demographic data about cancer. And of course, diabetic data I had to get from other people, of course, in Chennai, Viswanathan Hospital and Mohan Diabetic Clinic. So thank you very much for the opportunity. The first authentic statistical data on cancer incidence and pattern of cancer came in 1984. The National Cancer Registry Program of ICMR since 1982 guarantees uniform and continuous data collection from across India. Ever since, there has been a steady, progressive annual increase in incidence of cancer. The magnitude of the problem is reflected in the burden of cancer. Is cancer on the increase? Most certainly, yes. Cancer increases with age, and the longer one lives, risk of cancer increases. Very soon, we may need separate geriatric cancer group like pediatric cancers, and management can be very, very difficult. Starting with a burden of 493,000 in 1984, in 2010 the burden was 999,000, and it is expected to be 1,343,000 by 2020. The WHO, in its status report on prevention and control of non-communicable diseases, has referred to epidemics of non-communicable NCDs, as they call it, emerging or accelerating in most developing countries. NCDs constitute the leading cause of death and disability worldwide. The increase in NCDs is a result of increase in life expectancy, control of communicable diseases, and lifestyle changes. In India, the increasing trend of cancer, diabetes, and cardiovascular disease has become a major health problem. All the three are virtually common risk factors: tobacco consumption, dietary habits and factors, and including a genetic component. Lifestyle changes are basically related to improve socio-economic conditions, urbanization and industrialization. However, it has been documented by WHO that although NCD epidemics originate in the upper socio-economic strata, they diffuse across the social spectrum, with social gradient reversing and the poor becoming predominantly affected. In the more mature stages of the epidemic, the poor are the worst affected in terms of the disease and usually the more marginalized. With well-documented preventable risk factors, the major thrust should be primary prevention and control of risk factors in a planned, concerted, integrated manner. A vital component of primary prevention will be continuing public education, which will start at the school level, if possible even at the parental level at home. It has to be reiterated that most of the risk factors like tobacco habit, alcohol consumption, etc., I call them diseases. They should be prevented before they are acquired. Prevention is better than cure, and our experience at the Institute clearly shows that once the habit is established, acquired, the quit rate is extremely miserably low and can be most frustrating. Lifestyle associated diseases are insidious in onset and take a long time to develop and gives a chance for prevention. Fortunately, they are preventable or can be reduced with changes in the environment, habit and diet. The other important risk factor in all the three major NCDs, cancer, diabetes and cardiovascular disease, is in the genetic component. This has to be addressed in the genetic laboratories. The genetic components vary and are different in each condition, but there are integrated genetic factors also. Inherited cancer syndromes, usually involving germ-like mutations in tumor suppressor or DNA repair genes, may account for 4% of all cancers. Today, specific genes involved in susceptibility to many cancers have been identified. Inherited mutation of BRCA gene account for a small proportion of breast cancer. The affected family members have a lifetime risk of over 70% for developing breast and ovarian cancer. Identification of genetically susceptible individuals by confirmation of the gene defect is possible today. Now let us come to cancer in India. 1.2 million new cancers are diagnosed every year at 85.5 per 100,000 population. The rate per 100,000 population of all cancers together is almost twofold higher in the urban area than rural registries, 120 and 70 respectively. The incidence rate of 100,000 increases as age increases for most cancers. I think it is terrible when you see from 1534, 35, 64 and in the 65 plus, the thing goes up. The female predominance was seen in 1:1.03 with increased cumulative risk 1 in 10 compared to men 1 in 11. The incidence rate shows an annual increase of 1.3 in male. The annual burden increased by 5%. It changed. Of course, this happened earlier when we had the girl child and other problems were there. Now let us come to cancer in women, the Indian scenario. On a global perspective, there are marked geographical variations in overall incidence, sex ratio, pattern of common cancer sites, and their ranking. The differential patterns are related to distinctive environmental factors, essentially socio-economic variations, personal habits, like tobacco and alcohol, lifestyle factors including dietary habits, exposure to infection, occupation, etc. Survival and mortality also differ significantly in the two groups. The crude incidence rate in women is lower than in most developed countries. The crude incidence rate in women in India is 96 per 100,000 population, which is 2015 data. The major problem, however, is the burden, which is the combination of risk and demographic effect. Overall, there is an average increase, 1% increase in the incidence and translated into 4% increase in new cancer burden in the corresponding period. The lifetime cumulative risk of 0 to 74 years of acquiring cancer in women, which are in urban India, is 1 in 7 to 10, whereas in the affluent countries it ranges between 3 and 5. As for sex ratio, the male-female ratio, I think already said, is 1:0.9, and in the cancer, this is in the population in general. The cancer population, the ratio is 1.103, whereas in the affluent countries, the male-female ratio is entirely reversed. In the population, it is 1:1.05, and in the cancer population, 1:0.84. So they are totally different from the other world data. The cancer pattern in women is has been steady right from the beginning. Breast, cervix, and ovary, 3 top cancers at present, constitute nearly 48% of all cancers in women. Other cancers constituting only 52%. I think that ovary is not the correct one. Breast, cervix, and oral cavity, I think there's some mistake in that. There is an increasing trend in cancers of the colorectum, thyroid, and lung, which constitute together 10% of cancers in the more recent years. This will be after 2003, 2005. Uterine cervical cancer occupied the top rank, and breast cancer the second rank in women till 2001. Over the last decade and a half, there has been a steady increase in breast cancer incidence and a slow and steady decline in cervical cancer incidence. And today, breast cancer holds the top rank with cervical cancer, the second being the second rank only cervical cancer. The change in the trend is also accompanied by a parallel rise in endometrial and ovarian cancers. The change is unfortunate. Breast cancer screening is more expensive. We do not have definite screening technology for ovarian cancers. Moreover, ovarian cancer is the most fatal of all gynecologic cancers. Tobacco-related cancers, which cause oral cavity, pharynx, esophagus, larynx, lung, etc., constitute only 14% among cancers in women. It is essentially tobacco chewing. There is a declining trend in oral cancers, which is related to reduction in tobacco chewing habit, especially in the younger women. And I'm happy to tell you it is very much related to education. The study of factors in the decline of cervical cancer in the absence of any organized screening program in India has more than clearly demonstrated literacy and income level as significant contributory factors. I think it is very, very clear. You will see from the slide, there is a and breast cancers. Poorer literacy levels are associated with higher cervical cancer and lower breast cancers, and higher education level with higher breast cancer and lower cervical. It is so very clear, it is impossible not to believe it. These are all data collected by our demographic registry. We have a registry not only in collaboration with the ICMR, which covers the entire country. We have a separate registry for Tamil Nadu only and covers all the districts of Tamil Nadu. In an effort to study the variations between the literate and the rural and the urban is true, the Cancer Institute undertook a major Tamil Nadu Cancer Registry project from 2012 in collaboration with the government of Tamil Nadu, covering an area of over 50,000 square miles and a population of 73 million to study the differential cancer pattern in the urban and rural setting. The preliminary results seem to confirm the differential pattern with minimum variations. The highest incidence of cervical cancer is 56.1 was observed in Perambalur district with an 83% rural population, compared to 16.6 in Chennai, 100% urban in Tamil Nadu. For the breast, the highest incidence was in Chennai, 38.3 was the least incidence, 7.9 was in Krishnagiri district with a 22% only of urban population. Cervix was the commonest cancer in 21 of the 32 districts in Tamil Nadu, comprising 75% of rural population in the state. There is also a significant variation in cancer incidence even among neighboring districts with different urban-rural distribution, higher cervical cancer among rural women and higher breast cancer among urban women. Both are clearly related to lifestyle. Now, I think having completed our data on cancer, let us see what we have between cancer and diabetes. I think I had very little time, about a month, to prepare our diabetic data in relation to, we have the whole data. I mean, I never realized that there is so much data. And I started the program, and I think very soon, probably in about 6 months to a year, we have more data. I mean, I never realized the two together, diabetes and cancer together, can formulate so much. Women with diabetes are at a higher risk of certain cancers. In women, it is a risk of cancer breast, endometrium, ovary, cervix, and colorectal. The association between diabetes and cancer in women, especially breast, endometrium, and colorectal, may partly be due to shared risk factors, aging, obesity, diet, and physical activity. And the postulated mechanism is hyperinsulinemia and hyperglycemia. Risk factors for diabetes and breast cancers are overweight, obesity, calorie diet. I don't have to mention it to you here. Advised risk of cancer would be healthy diet, low calorie, low fat diet, physical activity, weight reduction, and the same thing that happened to the advice to a diabetic patient. Diabetic should be counseled. Diabetics, people who have diabetes, should be counseled to have screening for cancer based on age and sex. Diabetes in India, I think they've been able to get data from all over. I thank them for I acknowledge them for this data. Prevalence of diabetes is estimated as 65 million cases at 7.3 per 100 subjects, and a prevalence rate ranging between 2.3% to 10% in different states of India with male predominance. There are significant variations in different states with increasing prevalence, with increasing age. I think this is a large Indian study. Prevalence is double in urban 11.2 versus rural 5.2. Prevalence is higher in high socio-economic status than low and middle income group. Prevalence show a trend of 1.3% increase per annum. A comparison of prevalence statistics in cancer and diabetes is interesting. A comparison of prevalence statistics shows India accounts for 5.3% of world data and cancer burden. 5.3% of world cancer burden and diabetes accounts for 15.4% of prevalence cases. Mortality statistics of cancer and diabetes is revealing India accounts for 8.2 deaths due to any cancer and diabetes accounts for 8% of deaths globally. Death rate due to cancer is higher than the death rate due to diabetes. Genes associated, gene testing for susceptibility to define disease in an area of interest, and gene involved in susceptibility, which I have already told you. The maximum study has been susceptibility to breast cancer and BRCA 1 and 2. The inherited mutation to BRCA 1 and 2 accounts for a small percentage of cancers, 10 to 15%, what we call the genetic predisposition. The familial risk of a mutation positive breast cancer patients has been identified as 3-fold increase for first degree relatives, 6-fold increase for those with multiple first degree relatives, and normally familial cancers have an early onset disease and are more aggressive. And the advice we give for the positive, the family member of a positive BRCA who is affected with cancer, breast conservation, we do not advise them. Now today is a day of breast conservation with earlier detection. We don't need to do a radical mastectomy, but we try to avoid it in these patients. Radiotherapy is to be avoided as a possible positive factor for mutation, and bilateral salpingo-hysterectomy, possible tubal and ovarian cancer, and predictive testing for the unaffected members, because this is possible and readily available. The genotype-associated studies have identified diabetes associated with genes that may contribute to colorectal cancers. Few other associations of type 2 diabetes and breast cancer have been observed in the Caucasian, Hispanic, and South Asian population. Now we study again at the institute, we took a few years together, the occurrence of diabetes as a comorbid. In a study of diabetes as a comorbid admitted for treatment in 2014-15, it's just a 1-year study, irrespective of stage or stage of disease, the prevalence of diabetes was highest 40% among endometrial cancer patients, 27.1 in breast cancers, 21.1 in ovarian cancers, and least in the head and neck cancers, 15.1. The trend of diabetes as a comorbid is something alarming. A study of the trend as a comorbid patients for treatment over 3 consecutive time periods, 2001 to 5, 2006 to 10, 2011 to 15, showed an annual 2% increase in prevalence of diabetes as a comorbid. 18.8%, 19.1 and 25.2. This is statistically significant. I said alarming because this is a study only up to 2015. Now, more recently, after I started studying my data from this meeting, I started looking. Today, in the OP, yesterday, every other patient with breast cancer has a diagnosis. It is tremendous. I think if I go to study it, it is going to be alarmingly high. And the family history, I think, is there. And not only that, I'll come to that. The trend of prevalence of diabetic patients treated for cervix was also significant. It was 8.4%, 11.5 and 16.5. The same is true for ovarian cancer, and it is again statistically significant. This was not reflected in the corpus luteum, although it was high, because I think the cases were few. I think we have to wait for some more time. And then the overall survival of cancer patients in different sites, with and without diabetes, being evaluated. Breast, cervical, ovary, and head and neck. In breast cancer, there is no difference in survival between those with and without diabetes. But in every other area, cervical cancer, ovary, and what's the other one? All of them were significantly poorer survival in the one affected by diabetes. Definitely and clinically, it is very clear. We are not able to account for the no difference in the breast cancer patients. I think we need to study little more carefully. Now, the survival is irrespective of disease, and we need a more careful study, which I have already mentioned, without diabetes. Again, this is very interesting. In any oncologic institution, lifetime follow-up of patient treated is vital. I do not think we have it in the country, and we are one of the institutions, probably one of the only, and now pretty more after ICFR has come into the picture, having a lifetime follow-up of every patient treated. And follow-up of this patient, the cumulative risk of a second cancer at 10 years from diagnosis of the primary breast cancer was 4.1 among patients with diabetes and 2.8 for patients without diabetes. It is, although it may not be statistically significant, I think it needs to be carefully followed up. With all the available information and the increasing trend, we need to concentrate on prevention. The concept of prevention, I think, is available everywhere. Everybody knows that one of the most important that we need to do is prevention is always considered along with early detection. Early detection is actually secondary prevention. Primary prevention is the elimination of protection or protections from facts known or believed to be involved in the causation of cancer. These can be tobacco-related cancers, occupational cancers, and detection of pre-cancer. Primary prevention and pre-prevention will be to prevent occurrence of cancer, to prevent initiation of carcinogenesis or halt it before the pre-malignant lesion occurs. I'm not sure what we can do to prevent diabetes. The conceptual advances today on prevention is study of biomarkers, chemo and nutritional prevention, study of molecular mechanisms, and they happen to be the front-end research areas today. The concept of health screening is extremely useful in common accessible cancers and can effectively reduce morbidity and mortality. Screening programs can detect 3 to 4 times more pre-cancers as cancers. This is primary prevention and can cure with a curability of 100%. Screening of high group can be a major component of health screening. Now, I come to the end of my talk. I think I've taken more time than been permitted, I think. The last 6 decades has been seen phenomenal changes in the cancer horizon, beginning with an understanding of the biology of the complex phenomenon cancer, proliferation in technology, diagnostic and therapeutic, dawn of the chemotherapy era, the changing concepts in management, etc., etc. We have certainly come a long way. There is increasing survivors, improved quality of life, but we cannot live on our achievements. Our failures have to be our challenges. The pivotal area for action is preventable diseases. Not only cancer, all NCDs are preventable. I think we have to concentrate on them. Advances in research which have improved survivors, I think, have to continue. We have to reduce the gap between the state of art and minimal treatment, reduce the gap between research and clinical application. And I think I would like to say that the greatest challenge in medicine, in medical profession, has been humanism. Practice of medicine is an art, not a trade, a calling, not a business. Thank you for listening.
Statistics. If you have diabetes, your chances of getting a second cancer when you have breast cancer is more. And on startling facts, I think this should be made publicly known all over India, not just to this 150 people who come here. I think it's absolutely fascinating data, and I would request all of you to give a loud applause again to